Well, good morning, everybody. My name is Britt Nicholson, and for those of you who I haven't met before, I'm the Senior Vice President for Development here at MGH. This is actually our 16th Mass General Answering the Call webinar, which began soon after the onset of COVID. And today's topic, which is especially timely, is pandemic to endemic. What do we do with this next phase? So just a couple of reminders. No microphones or video capabilities are needed to participate. And at any point during the webinar, you're able to ask questions. And you can do this anonymously if you wish through the Q&A feature, which is at the bottom of the screen. We like the questions to be as focused and as brief as possible. The main reason for doing this is to make sure that we get to as many questions as we can during this 45-minute period. So let me give you a quick overview of our speakers and how the event will flow. We're very fortunate to have Dr. George Alba joining us today. And Dr. Alba is joining us in his capacity as the Associate Director of the Coronavirus Recovery Clinic at Mass General, or the shorthand is really the Long COVID Clinic. Next is an individual who is familiar to many of you, Dr. Paul Biddinger. Paul was, if I remember correctly, Paul, I think you were actually one of the speakers at our very first Answering the Call webinars. And Paul is the Chief Preparedness and Continuity Officer at Mass General Brigham and is the Director of the Center for Disaster Medicine at Mass General. So what we'll do is that each speaker will initially introduce their topic, talk for several minutes about their role, the work that they do at MGH, and how their role has actually shifted during the pandemic. And they'll speak briefly to the topic which they're sort of best equipped to address. And then as soon as they finish with their introductory remarks, I have several questions I'd like to pose to each of them. And once we get those questions, we're going to open it up to the audience for your questions. And so let me proceed right now by turning the microphone over to Dr. Alba.
Thank you for the introduction, Dr. Nicholson, and thank you again for the invitation to be here today. So as you heard, I'm a pulmonary and critical care physician and researcher, and I'm also the Associate Director of the Coronavirus Recovery Clinic here at Mass General. Before the pandemic, my research focused on mechanisms of lung blood vessel dysfunction and the development of new treatments for rare diseases that affect the lung blood vessels. And during the pandemic, I put a pause on that research to care for the exploding population of critically ill patients with COVID-19. And that included starting a dedicated clinic to care for the hundreds of ICU survivors that we were seeing in the hospital. What we didn't anticipate at the time were the hundreds of patients that were never in the ICU, but went on to develop persistent debilitating symptoms following their seemingly mild initial illness. And so as a result, my research has now expanded to study the lung blood vessel dysfunction that we see in patients with severe injury from COVID-19, but also to better understand why patients develop persistent symptoms following COVID and how we can better treat them. And so I'll hope to touch on some of these topics during the Q&A today and showcase what I think is some of the incredible collaborative work that's being done across Mass General to meet the current challenges of the ever-evolving pandemic. So I'll now pass it off to Dr. Paul Biddinger.
Thank you so much. So I am Paul Biddinger, and it's a pleasure to see many of you again that I've had the good fortune to speak with in the past. As Britt said, I head the Center for Disaster Medicine at Mass General, which is an institute or part of the hospital designed to improve overall healthcare readiness for disasters of all types. It was 20 years in the making, and I think really helped Mass General prepare for the pandemic. In the early stages of the pandemic, we actually took the tools we've developed for the whole hospital and shared them across not just Massachusetts, but New England, and in fact, nationally and internationally. A lot of the tools became parts of state hospital association protocols, state health guidance, even international guidance. And so I'm continuing to work on how we can better prepare the healthcare system for disasters, how we can learn lessons from COVID-19 and have a more resilient and robust healthcare system. Unfortunately, COVID-19 won't be the last infectious disease threat that we will face, and some things may be similar in the next epidemic or pandemic, but some things will be different. And unfortunately, we also have to be still ready for other threats, whether it's mass casualty events or power outages or severe weather, et cetera. So that's the work that happens in the Center for Disaster Medicine. As Britt mentioned, I'm also the Chief Preparedness and Continuity Officer now for the Mass General Brigham system. And we are really trying to take the incredible support for emergency preparedness that Mass General has had for so long, and with that support, all of the great work we've been doing at Mass General, and spread that across the Mass General Brigham system so that all of the hospitals have similar levels of emergency preparedness. And as we work with our system, we can share those lessons with other systems that don't have the same kind of depth of bench resources that we have at Mass General, and therefore end up with a more prepared, a more resilient healthcare system overall. So really eager to be part of this conversation, thrilled to be able to join you again. And I will stop there and turn it back to Britt.
Well, thanks very much to both of you. George, I'm going to start with you. What are the most common long-term effects of COVID-19, and is there a particular demographic that is turning out to be the most susceptible to these long-term effects?
Yes, it's an excellent question, and one that is hard to answer briefly, so I will do my best. But over the last 2 years, we've learned a lot about the possible long-term effects of COVID. The good news is that the vast majority of people who get COVID never go on to develop persistent symptoms. And there are actually emerging data that suggests that vaccination decreases by half the odds of developing persistent symptoms after COVID. So good news there. However, current epidemiologic data suggests that about 10% of patients will go on to experience symptoms that last beyond a month, and around 2% will experience symptoms that last beyond 3 months, which doesn't sound like a lot, but when you apply it to a global population, that becomes rapidly a pretty significant public health crisis. And so what we do know is that regardless of the initial disease severity, patients can have prolonged symptoms following their initial illness, often involving multiple organ systems. The most commonly reported symptoms often include neurologic ones, so things like debilitating fatigue, headaches, dizziness, and cognitive impairment, or what patients will sometimes refer to as brain fog, as well as respiratory symptoms, things like shortness of breath and decreased exercise capacity and cough, as well as cardiac symptoms and musculoskeletal symptoms. So a pretty broad array of symptoms. And so far, risk factors for long COVID appear to be increasing age, increasing body mass index, female sex, and then the more severe initial illness at presentation. So one thing I will say is that long COVID is not one monolithic disease with one clear cause. Patients really present differently, and there are likely many different explanations for why the symptoms develop. And similar syndromes have been described following other infectious diseases. So this is not unique to COVID, but we're just seeing so many patients with one infectious disease at one time, more than ever in our modern history. So really our job in the clinic is to try and understand how patients cluster by the complications and symptoms that they experience. So for instance, patients who survive being in the ICU you have unique symptoms and issues that are typical of patients who are ICU survivors. And patients who are at risk for being in the ICU are unvaccinated, older age, or immunocompromised. And then as another example, patients who present with the more debilitating neurologic symptoms, we will manage those patients in consultation with our neurology colleagues as we're making increasing diagnoses of autonomic dysfunction and small fiber neuropathy, as opposed to patients who come with inflammatory lung injury, which is more within our own wheelhouse. The patients who are at risk for the autonomic dysfunction tend to be younger women, and they often tend to be show signs of autoimmunity. And so we're still learning a lot about this, and this is one area that is undergoing a lot of investigation to figure out new treatments.
So, George, you used the term autonomic dysfunction several times. The audience may not be familiar with that term. Could you expand on that?
Sure. So the autonomic nervous system is a component of our own nervous system, and it helps regulate things like blood pressure and blood vessel tone in our body. So when there's dysregulation of that tone, patients can experience low blood pressure and dizziness from the low blood pressure or fast heart rates. And so that's one of the types of symptoms that we see in the patients post-COVID. Thank you for the clarification.
And George, you also mentioned that what we're seeing with long COVID was not too dissimilar to what we were seeing in terms of the long-term effect of other illnesses. Is there any overlap with what's been known for years or described as years as chronic fatigue syndrome? Yeah.
Yes. So myalgic encephalomyelitis and chronic fatigue syndrome, ME/CFS, quite a mouthful, is a clinical syndrome that's been diagnosed after other infectious diseases, things like Epstein-Barr virus, Lyme disease have been posited as potential causes for ME/CFS. We definitely see patients who meet the clinical criteria for ME/CFS. And actually, David Sistrom is a pulmonologist at the Brigham and has generated the largest cohort of patients with ME/CFS and has done really interesting invasive exercise testing on those patients. And about a third of those patients end up having autonomic dysfunction of that autonomic nervous system, and evidence of small fiber neuropathy. So there's a lot of overlap in patients that had this syndrome from other causes before the pandemic to what we are seeing now. And so there are a group of patients that we see that meet the clinical criteria. That's part of what we do in the clinic, is try to identify those patients and route them towards the pathways of care.
So how are you and your colleagues currently researching long COVID, and how has it informed the development of new forms of either effective treatment or prevention? And if you have any examples, that would be great.
That's directed to me?
Yep.
Yeah, so I think it's an ongoing process. So from the onset of the pandemic, Mass General has done an amazing job in responding to meeting the needs of patients. That, of course, was the initial response to all of the acute care orchestrated by Dr. Biddinger. But also in the ways that we are now trying to orchestrate the care of patients after. And part of that response is to just collect data and biological specimens from our patients so that we can learn as we go. And it's how we were able to recognize kind of the different manifestations of long COVID early on, to collaborate across disciplines early on, share observations, and really provide care for patients before we even really had any idea what we were dealing with. And I think I'll give you some specific examples, but this collaboration across the institution really positioned us well to be part of the multi-million-dollar NIH RECOVER study, which is the largest epidemiologic cohort of patients in the United States to study and follow patients with long COVID. And so Mass General, Brigham organized this effort, and we're part of a group of hospitals across Boston, the Boston COVID Recovery Cohort. And we're actively enrolling patients and studying patients to understand causes of long COVID. Within our own pulmonary divisions, my colleagues and I have come together to basically leverage the robust resources that we already had. So for instance, we are using our cardiopulmonary exercise testing laboratory to better understand the causes of exercise limitation and shortness of breath that we see in patients with long COVID. We're using advanced imaging techniques like dynamic contrast enhanced MRI or endobronchial optical coherence tomography, things that we've been studying in other lung disease. We're now applying it to patients with long COVID to better dissect and understand the causes of lung disease in patients with long COVID. So all of this research is integrated into the coronavirus recovery clinic, which so it allows us to both care for patients, but also study patients as we go and learn through the pandemic.
One more question for you, George, before I move on to Paul. You mentioned that this could affect the lungs, it could affect the autonomic nervous system, it can affect the heart. So as we're learning about this and moving forward, how do you advise patients that they adjust to living with this disease as we're learning more?
Well, I think for patients that have long COVID, a lot of it has to do with what kind of manifestations they have. And for the most part, the prognosis is very good. There are known disease entities that we have seen before, and we have a good sense of the trajectory. For patients that have or undergoing the evaluation, we've come a long way from the first time I was seeing patients 2 years ago, where I had no kind of script for how I thought about these patients, to now where we're able to get them to the appropriate clinicians. And so for the patients that have ME/CFS, the chronic fatigue syndrome, or the autonomic dysfunction, those are challenging diagnoses that require really intensive multidisciplinary care. But we at least now know that patients need to get to that point. And we know how to get them to that evaluation. But I think the most important thing for just patients in general is to try not to get long COVID. And I think public health measures that emphasize prevention, so vaccination or the early administration of outpatient antiviral therapies, are going to be key to decreasing the incidence of infection and then the complications thereof.
Great. Thanks so much. Paul, I'm going to turn to you for a couple of questions. I think the first one is we entitled this answering the call, a pandemic to endemic, and can you give us a definition of those two terms and why it's important to be considering this?
Sure, absolutely. So pandemic is a global spread of an infectious disease with severe outcomes. And so, often thought of as a wave, although certainly after 2 years, this seems like a very, very long wave we've been going through. An endemic describes diseases that are in the background, that are part of a community. And it doesn't necessarily mean that they're not severe. For example, malaria is endemic in a lot of parts of the world and causes, unfortunately, a lot of illness and death, but it's expected to be part of the background infectious disease of the community. And I think, when we talk about pandemic to endemic, I think we are talking about not thinking of this as a wave that will pass and that will go away, but more something that we have to live with and manage. And I think there is actually a lot of hope, and George has touched on a little bit of this already, that we know that vaccines, even just the initial vaccines without boosters, vaccines make a big difference in preventing severe illness and death. As George and his colleagues were so heroically doing in the first wave, when we had so many patients in the ICUs with COVID, each of the subsequent waves we've now had 3 waves in Massachusetts, has had fewer and fewer number of people in the ICU. And that's due to a lot of different factors, but one of the biggest certainly has to do with vaccination. Then boosters, of course, further decrease your chance of severe illness and death. But recent boosters, and we'll talk more about boosters, I expect, a little later, but if you've been relatively recently boosted within the last, say, 3 to 6 months, decrease your chance of getting any infection from COVID overall. And then George did touch on the therapies that we have. We have some infusion therapies like monoclonal antibodies or remdesivir, and we have some pill therapies like Paxlovid or molnupiravir. And all of those therapies, on top of the benefit we already have from vaccination, from boosters, decrease your chance of severe illness or death by as much as 80%. And so when we start talking about managing COVID, limiting the number of people that are in the ICU, limiting how sick people get, we can really make a huge difference still in preventing people's risk of hospitalization, being in the ICU dying, if they're vaccinated, if they're boosted, if they get tested as soon as they have symptoms, and then if they test positive and are at high risk, they get an antiviral therapy. All of those things make it much, much, much less likely that we're going to have big waves of people who are severely ill, that need hospitalization, that will put demand on the medical system that we've had that's displaced other care.
So this next question is, I think, impossible to answer, but it's a question that's on everybody's mind. It actually has 2 parts. The first is, should we be worried about new variants in the future? And the second is, what should we be prepared for specifically in this coming year ahead?
Yes, obviously the last 2 years, every time someone makes a prediction, they're pretty quickly proved wrong, and so I get very, very nervous about making any predictions. But I think one prediction that is certain is that there will be more variants. The coronavirus has proved itself quite adaptable and quite malleable, and unfortunately, we know that there will be new versions. What we can't say is what those versions will mean in terms of clinical consequence. The most significant thing we worry about is really, or it's two things. One is a degree of immune evasion. So will the next variant decrease our protection from vaccination, decrease the effectiveness of our therapies that I was just talking about? And the other is will future variants cause more severe illness? Thankfully, with Omicron, now with BA2, the current variant that we're seeing dominant in Massachusetts, they are unbelievably transmissible. BA2 may be among the most transmissible respiratory viruses we've ever seen in history, but it causes far fewer critical illness cases than the original versions of COVID did. So we hope that future variants won't cause severe illness. So far, we have seen good preservation of effectiveness against severe illness and death, even though we know that the original vaccines weren't nearly as effective at preventing symptomatic illness, of mild illness with COVID.
So Paul, you've served in a major leadership role right from the get-go, going back actually to January or February of 2020, even before the big lockdown. What would you say has been the biggest lesson you've learned throughout this pandemic? And of those lessons, how will MGH prepare differently for the future?
Wow. Yeah. So a couple of things. I think since I have about 5,000 most important lessons, it's really pretty hard to get down to one. I might cheat and at least try and give two. I think the first, and you'll expect this from a guy who focuses on preparedness, but is that preparedness works. I will forever be so grateful that I work at Mass General in a hospital that for decades has invested in emergency preparedness. And we had plans and resources and systems, and we frankly have a leadership culture that adapts. And George will remember this well, but we were opening up a new intensive care unit in March of 2020, almost every 1 to 2 days. For a hospital that still has the greatest number of critical care beds in New England, we normally have about 50 patients on ventilators on average, and we had more than 180 patients on ventilators at the peak. And we could not possibly have done that had we not had the breadth and depth of preparedness work that we had at the organization. And again, as I said, I think unfortunately there are other threats still out there that we need to continue to prepare for. And so COVID has been very validating in terms of showing that the systems we have been investing in, we've been putting so much work into, that they pay off. Again, there's so many other lessons. I'm hesitant to only name one other, but I think one of the most important lessons coming out of COVID is just the reality of the impact of health inequity and health vulnerability on disasters. That we clearly saw the disproportionate impacts in certain communities in Massachusetts on racial, ethnic, minority populations, on others. And I think what we have to do, what I'm going to do personally in my own disaster work, is kind of come back to the drawing board and look at how we can do a better job of really planning for the needs of those communities from the beginning. Across the whole country, we start with general emergency operations plans and plan for disasters for whole communities, and then think about who's vulnerable and try and meet their needs on top of what we've done with our general planning. I think it's actually time for a paradigm shift where we start with those needs. We know for sure that the most vulnerable will suffer the most in disasters. Let's start with planning to meet their needs and see how we can expand our plans to meet the overall needs of the community. And that's a daunting challenge, but I think it's one of the most important we're going to face.
And this next question, which is the last question before we get to the open question and answer from the audience, I want to direct to both of you. And I'll start out with fully understanding that neither one of you are pediatricians, but again, this is a question that's out there. Do you have concerns of long-term effects of COVID on our pediatric population? And do you have suggestions on how to help our children adjust to the new normal and anything to watch for in their future?
Well, I might start, and then I'll definitely turn it to George. I think, absolutely there will be there are long-term effects from COVID on the pediatric population, but most, I think, are social and societal. I think we just continue to learn more and more how disruptive this has been to children's lives, what the mental and social impacts have been. You hear from teachers that children are 1 to 2 years behind in their social development, that there are all sorts of challenges that are new. And I think we will unfortunately continue to learn a lot more about this in the coming years. Thankfully, as we all know, COVID has been relatively less of a health threat to them than as compared with older individuals. But it's not to say that there aren't health threats. George may want to comment on this, but we know that long COVID is a thing for kids as well. And so certainly as soon as we're able to start vaccinating kids under 5, there's going to be, I think, an important incentive to do that. And I think we are going to have to help kids as well as ourselves figure out what sort of living in this new era means when you don't go to school when you're sick, you don't go to practice when you're sick. That's not the way any of us was raised. We were meant to tough it out. We were supposed to just show up just because it was a sniffle. And this will, I think, profoundly affect their lives, and we're going to have to figure out exactly what that means.
I don't know that I have much more insight beyond what Paul just eloquently stated, but there are children who certainly have symptomatology consistent with some of the long COVID symptoms that we see in adults. Thankfully, it is rarer, but it's still possible. I do agree that the implications for children are probably more along the social. This is something that I think about all the time with an unvaccinated toddler in my house, making sure that she's both safe, but also socially acclimated and ready to go to school. So something that I think about all the time. But again, I think I don't know that I have much more to add beyond that because I obviously don't take care of patients, pediatric patients in the core clinic.
All right. Well, as usual, we've got some great questions coming in from the audience. Paul, I'm going to direct this first one to you. Again, it's really multiple questions in this one. Do you anticipate COVID rates increasing as people go back to the office? And then there were 2 sub-questions under that. One is, how can we protect ourselves in an office setting? And how concerned should we be about taking public transportation?
Got it. Yeah, lots of good questions in there. I think, the most immediate reason that I think, unfortunately, we have started to see cases rising and probably will see cases rise for a bit is the BA2 variant that we now have. This new variant of COVID. It's the dominant strain in Massachusetts and pretty much everywhere else in the world where it's existed. We've seen rises in case numbers. I am somewhat gratified that although we've seen cases rising in Massachusetts for the last week or 2, they've not been rising dramatically, and we similarly have not seen a significant rise in hospitalizations, though, as I think I've probably mentioned in this forum, that's an indicator that lags about 2 weeks behind overall cases. In terms of going back to work, I think we know a lot about how people can work together safely, that keeping some distance when you need to, making sure you're in a well-ventilated workspace is good. And for those who are concerned or for those who have risk factors, masking certainly is very appropriate. We know, again, that masking protects the wearer, which is data amazingly we didn't have at the beginning of the pandemic. We masked to protect each other, but now we know you can mask to protect yourself. And again, you've got other tools that protect you at the workplace, such as vaccination and boosting, that really do decrease your overall risk of infection, and therapies if unfortunately you were to become ill. For public transportation, I think masking is a very effective strategy that helps a lot. We know how little COVID is transmitted through surfaces, so you can do a good job of protecting your respiratory system with a good mask. I think we will see fewer numbers of cases from the return to work side of things and more just from the variants as they evolve.
Paul, George, there's a question that came in around the fourth booster shot. I guess one question is it assumed that that fourth booster will be available to all in the next few months? And what are your thoughts about the fourth COVID vaccine for seniors? Get it now or wait for a vaccine that's more targeted to Omicron?
This is something that my patients ask me every day, and I trust the CDC and their recommendations, and so I've been advising that those over 50, as recommended, get the fourth booster shot now. We know that the boosters, as Paul mentioned, help with neutralizing current variants and reduce the incidence of hospitalization and death, which is something we obviously very much care about. So my recommendation is to do indeed get it now, as recommended by the CDC. I don't know if Paul has any other.
Yeah, so I'm definitely with George. I think there are kind of two schools of thought out there. One is we certainly I expect that there will be another wave in the late fall and winter as we've had for the past 2 years, and we know that having received your booster within the last 3 to 6 months is more likely to be protective. And so people have talked about timing your booster then. There's a whole separate school of thought that says, people also try and time the stock market and don't do terribly well buying high and selling, buying low and selling high, excuse me. And we've been proved wrong again and again with COVID, so trying to time this is difficult. The only thing I would add to the timing question is actually, I think my understanding is there will be data emerging in late June, early July that will talk about an Omicron specific booster. And so we may learn more about whether we change the formulation in our boosters. Right now, we've still been boosting with the original vaccine that's targeted against the original coronavirus variant. So if anyone is looking for timing on that, it's probably about 2 to 3 months that we'll have until we know that answer.
So Paul, for a variety of reasons, one, the size of the population, and two, the robustness of their public health network, these Israelis seem to be providing information about a variety of aspects of vaccines and treatment, earlier than the rest of the world. Have there been any information coming out from Israel about the utility of a fourth booster?
Yeah, so it's been a little bit mixed, and that some of the extrapolation of that Israeli data is what I think led the FDA and the CDC to recommend a booster for those over 50 and those with high-risk medical conditions. It's not clear that a fourth booster for all it has a population benefit, and so it really may be more about your medical risk. And of course, all along we've known that each decade of life puts you at higher risk for COVID, and there are folks because of their medical conditions that are higher risk. So, Israel, one of their great success stories is just how integrated their healthcare data is, and therefore how well they can provide population-based information. They've also taken a pretty aggressive and conservative approach to trying to really go after the virus as early as possible. So, obviously very aggressive vaccination campaigns, then some of the earliest booster, third dose, fourth dose booster campaigns in the world. I'm thrilled that we are able to learn from their data, and I expect in the next couple of months we'll actually learn a little bit more about what this fourth dose strategy means for them, about durability of protection as well.
George, this next question is coming in from the audience. My spouse developed myocarditis days after the second Moderna vaccine. How much of this complication have you seen in adults? Is myocarditis part of your long COVID study?
So any new medical condition that occurs after the diagnosis of COVID, or certainly after vaccines are being closely tracked, and they're going to be data points in this kind of large epidemiologic cohort. So this is definitely included in all of the studies. I will say that I have rarely seen myocarditis from COVID itself. We saw it a couple of times in the acute setting. I have not seen any myocarditis diagnosed as the cause of long COVID. And again, this is out of a population of like 600 or 700 patients that we have seen. So it's not every single patient. And I've yet to see a case of myocarditis in our clinic from a vaccine. We do know that younger men in particular seem to be at higher risk of developing myocarditis after the vaccine. And so those responses are certainly something that have been recorded. In terms of, whether or not it's always hard to know. I have patients who've developed a number of symptoms or conditions after their initial infection, around the times of their boosters or initial vaccine. It's always hard to know the timing and what is the initial cause of all of those particular complications. And so we try to do the best that we can in attributing it to certain causes. So I will say, thankfully, we've seen very little myocarditis. We've seen definitely more myocarditis from the initial infection, and in our experience, none from the vaccine.
George, this is almost a companion question. So if you already have autonomic issues from a past infection, do you think continuous boosters are still safe, even though the immune system is provoked by the vaccines?
Yeah, this is a question that comes up fairly frequently from patients who have not only autonomic issues, but other underlying medical conditions, particularly autoimmune conditions, where they worry that the immune activation may worsen their underlying condition. What I will say is that we saw a lot of patients' autoimmunity actually worsen after the initial infection with COVID-19. So it's always hard to know because again, this is all anecdotal at this point because we don't have large, robust data sets to really answer these questions, but I have not seen anybody have worsening of their pre-existing, in this case, autonomic condition or autoimmune condition from the vaccine to date. But I'm also seeing patients who had pre-existing COVID. It's always hard, again, chicken and egg, which immune activation event came first to decipher those two things. It's a question that I've posed to our neurologists about the safety of additional boosters in patients that already have autoimmune small fiber neuropathy from their initial COVID. And their general recommendation is the vaccines are safe in those individual patients if they've tolerated them previously, because they reduce the risk of ongoing repeated infections, or at least complications from repeated infections in the future, which we already know seems to have triggered that initial immune response. So it's complicated. It's a discussion that should be had with individual treatment providers and a kind of a discussion, because there's no clear answer.
Okay, thank you. Paul, this one's for you. The audience member says, Dr. Biddinger, I want to make sure that I'm not misquoting you, after this, webinar. It was my understanding after your comments that you said that variants that we're seeing turn out to be more infectious or more transmittable, but seem to lead to less severe disease, less hospitalizations. Is that a pattern that we should expect to see going forward with the variants, or is this just by accident?
Well, so that's what we have seen, both even with Delta and then Omicron and now BA2. With other infectious diseases in history, that has happened as well. That's actually what's happened with influenza in previous pandemics. All that being said, is there's absolutely no guarantee that that's the way it will happen. So we have seen this pattern emerge with COVID, which has been good that there's been less severe illness. George was talking about with long COVID that when you do the math for populations, that 2% of a very big number is still a very big number. And that is exactly what happened this winter with Omicron, is that the number of people infected with Omicron was so much higher than any of the previous waves we've had, even though there were relatively fewer people who needed hospitalization as a percentage. It still was a big number because so many people got sick. So, again, I wish we could guarantee that this is the way the variants will emerge. It's the way it's happened so far, but we don't know that will persist.
I'm not quite sure who to direct this one to, so this will be a toss-up. Each of you can weigh in. Transplant patients have had a particularly tough time, with regards to antibody responses to vaccines. What is on the horizon for transplant patients? And for example, Evusheld causes a high incidence of heart attacks compared to the general population. So
I'm happy to start on this one, Paul. So yes, patients who are immunocompromised certainly are at high risk for severe complications from COVID-19, including death, particularly those patients who are on medications that wipe out the immune cells that create antibodies. And so early administration, so vaccination is important, but because their immune systems may not respond, early administration of antibody therapies or antiviral therapies is really, really, really key for immunocompromised patients. So making sure that they know who to contact and those individuals who they contact know how to get them those therapies early are really important. And I have been using Evusheld, which is the intramuscular and antibodies. There are 2 antibodies that you inject that last for about 6 months, had great efficacy against prior variants. There's still some efficacy against the emerging variants, so the neutralizing data certainly goes down with the new variants. And I've been recommending it for patients who specifically do not create antibodies, because that at least gives them a little bit of pre-exposure protection. And then I still recommend that they get referred in for early antiviral therapies. So worth it ultimately. These are that medication is under an emergency use authorization, so it's not FDA approved formally. Before giving the patient Evusheld, we have a long conversation about the risks and benefits of the therapy. We go through the data sheet, specifically addressing what was highlighted in the question, which is the increased incidence of cardiovascular complications that occurred in the patients that received Evusheld. And ultimately, the benefit of the therapy, it outweighs the risk greatly of the potential risk of cardiovascular complications, because these patients do really, really poorly in the intensive care unit and develop pretty significant lung disease as a consequence of this. So in general, any early therapy we can give to help out the immune system in these patients is key.
Yeah, and I would just underscore that. So just for clarity again, Evusheld is the one preventive therapy or prophylactic therapy that we have besides vaccination and boosters. And in the right population, I completely agree with what George said. I think certainly for anybody who's at high risk, and this includes the transplant population, really early testing and early access to therapies. The monoclonal antibody infusions, again, they're like infusing an antibody response if you can't make your own, and the antiviral therapies, tilt the odds in your favor in terms of just decreasing the viral load. So thankfully, we do have tools we didn't have even a year ago that make things better for those who are medically vulnerable.
Well, George and Paul, again, thanks for an absolutely terrific program. Once again, not surprisingly, we have more questions that came in through the question and answer period that we were able to answer. I'd like to thank all the attendees for joining today, and any additional questions, please email mghevents@partners.org. So that's mghevents@partners.org, and we'll do our best to get those answers back to you. Once again, thank you for joining. Thank you to our two presenters, and please be safe out there. Bye-bye.